Thank you all for joining our 2020 virtual summit. We are excited to be hosting this very, very relevant and timely discussion, medical debt in the age of COVID-19 and beyond. We are really facing dual public health and economic crises created by COVID-19, which have really exacerbated the problem substantially of medical debt, creating new financial strains not only on individuals, but also on our healthcare systems. We really want to make sure at RIP that we're propelling a conversation forward that really sparks a deeper appreciation of the problem and really contributes to our collective thinking about how we can do better. As long as there are people out there struggling with medical debt, we will continue to work and find it and abolish it.
Americans, because of our patchwork health insurance system, are exposed to significant financial risk. So you put together the fact that there is a high fraction of uninsured people, that coverage is becoming less generous, and the fact that many households don't have $400 in cash. And unsurprisingly, you have high levels of medical debt. These numbers are likely to be increasing as healthcare costs from the COVID crisis start transitioning into medical debt. But even just looking at the geographic pattern shows that there is a strong correlation between medical debt and collections and sort of minority communities. We are interested in the extent to which medical debt relief can spring people out of debt traps. So there is an old idea in household finance that some people are trapped in debt. That is, they incur one form of debt. That leads their credit score to get worse, which leads to higher interest rates on other debt, which means that they get further in debt on those products. And so what we're interested in is whether medical debt relief can turn that vicious cycle into a virtuous cycle. We are really excited to measure the impact of medical debt forgiveness that RIP has and to provide credible estimates for their donors about the benefits they're having. We think our research can also be powerful in identifying the groups of people who benefit the most from medical debt relief. And so figuring out what populations have the biggest bang for the buck allows us to target medical debt in a way that has the greatest impact.
I can tell you firsthand, working in South LA and working in various parts of LA, what it looks like to review some of the research, including some that was recapped today, but also research from the US Census Bureau, the Supplemental Poverty Measure, that indicates that medical expenses are the largest contributor to driving new poverty in America. This is more than credit card debt, student loan debt, medical expenses. So it means something, both as a clinician who takes care of patients who come in every day worried essentially about their ability to make ends meet, their ability to afford not just healthcare coverage, but also afford roof over their heads. It means something when the medical system, the very system that myself and many other clinicians are a part of, that ostensibly is there to make you better when you're sick. It's very problematic. It's morally injurious, right? It's disheartening. It leads to burnout when healthcare professionals on the front lines in these systems bear witness day in, day out to the fact that the very medical system that's ostensibly set up to try to help people get better is also complicit in making people get worse.
Emergency room visits are typically treated as a primary care physician's office at most community hospitals and most health systems. That is the most inefficient and most expensive way to receive care. And it's also the largest source of bad debt at a hospital, which ultimately manifests itself, and I agree with Richie, as the feature of medical debt within a hospital. The key to reducing healthcare costs upstream is having patients access care at the right time in a preventative manner instead of having the emergency department pick it up later.
One way to address the upstream issue of the incursion of medical debt is to not have medical debt incurred in the first place, because for lower income individuals, some of those services should be considered charity care. The bills shouldn't be administered, and that's, I think, a component of what is intended through community benefit and tax exemption.
Based on the data and the science and the evidence right now suggests that private equity care is not at all about health equity. In fact, it is monetizing health inequities.
For example, the outrageous disparities by race, by income, by immigration status, and how harmful and pernicious those are. You know from New York City that the hospital that was hit hardest was Elmhurst in Queens. Why? Because they take care of a large swath of patients in the central Queens for whom there is no other hospital. They are the only hospital, right? Manhattan is filled with hospitals. Queens, the immigrant communities, no. And our patients come to us because they feel protected, because they worry tremendously, not only about how are they going to pay the bills, but even if they're covered, will they be reported as being undocumented? Many people, even because the messages are so complicated and the legal issues are so complicated, they may be here completely legally and they're still worried about public charge.
And general Medicaid has just not fully met the mark in being able to provide the services that we care for in general, in a way that is really beneficial to really kind of providing that care that's reimbursed appropriately. So the history around that runs deep, and it's an opportunity to reevaluate that. I'm just hoping that moving forward, things are done differently. Hopefully that this is the tipping point or that rate limiting step for change. And people don't have to negotiate about their health around cost. It's insane that is still a part of the fabric of how we function, that has to be a part of the decision tree of the day.
I expect that this event has provided all of us with really helpful insights that are really going to reverberate in our thinking and our work ahead. And we couldn't agree more that these are systemic issues that have to be addressed. So we'll do everything we can to highlight the problems of medical debt and contribute to a better path forward. We hope all of you will do the same. Thank you for being with us today. This concludes RIP's 2020 Virtual Summit. Stay safe, stay healthy, wash your hands, and wear a mask. Until next time.